Great. Well, good morning, everybody. Thank you, Roger. Thank you, Stefan. Thank you to LMNA Cardiac for the chance to be with you all today. My name is Andrew Landstrom. I'm a pediatric cardiologist, and so my specialty are the smaller patients. As Roger mentioned, we do a little research as well. And so my goal for our 15 or 20 minutes together is to talk to you all as patients and families about what you need to know about the cardiac evaluation for individuals with an LMNA variant. And just by show of hands, if you feel a little brave and if you're willing, I'm curious how many patients or families we have in the audience. That's remarkable. How many might have been to one of these meetings before, like in Durham, North Carolina? Some know. Wonderful. Well, I hope that you find this helpful. We will get done in 15 minutes, so we have a few minutes for Q&A. I have no disclosures or conflicts of interest, which basically means I have no relationship with the industry, and I hope you find the perspective unbiased enough. So very briefly, an overview of what we're going to cover. We're going to talk about what brings families in when there's suspicion of LMNA disease. How do they present? How can LMNA variants affect the heart? And knowing that, how do we evaluate for whether the heart's affected? How do we treat the disease? And we'll talk in broad terms here. My LMNA positive child play sports is a big question. And where can I get more information? Spoiler alert, LMNA Cardiac and some other wonderful foundations are great resources for you. Let's begin. So what typically brings families in to be seen? Well, the risk factors that we think about, the symptoms that we worry about are things like fainting, but not any kind of fainting with exercise or fainting right after exercise. Should never be blown off. That should always trigger an evaluation. Of course, it's not always an LMNA variant, but it should always trigger an evaluation. Particularly, if you faint and you pop back up again, like nothing ever happened, you're not drowsy or confused afterwards, that also is kind of not a red flag, but an indication that perhaps something's wrong with the heart. Oftentimes when families come to see us as a pediatrician, the child may be asymptomatic, but we're asked to see the family. And that's because somebody in the family, maybe mom, maybe dad, in this silhouetted diagram, in this case it's dad, was found to have a positive variant for LMNA, and we're asked to evaluate the family. And so in this scenario, when dad got the LMNA variant, knowing what that variant is critically important because these are autosomal dominant genetic diseases, meaning it's a 50-50 chance that it can be passed from parent to child, regardless of the biological sex of the parent or the child, and that they will have that risk variant too. And so oftentimes our goal is to figure out among the children who's at risk. Common question is, how early should this be done? The answer is as early as dad was diagnosed. As early as the first person in the family is diagnosed with an LMNA variant that's disease associated, that's the best time to have everybody else in the family screened for that variant, including children, and the age of the children is never too young. So in this scenario, if dad's got the variant, the two younger daughters got the variant, the older daughter does not have the variant, we would follow, of course, the two younger daughters. The older daughter, unless there's some other concern, because heart stuff happens, unless there's some other concern for another heart problem, she doesn't do the same. We would follow the two children who are gene positive very closely. C, specialists. We were just having this conversation this morning. Specialists fall into two groups, the actual specialist and the person who says they're a specialist. I can't tell you who you see. I can't tell you whether they're a specialist or not, but there are resources for you to get a bit of a sense as to whether they may understand LMNA cardiac or LMNA mediated heart disease beyond the superficial. This is a great resource. This is LMNA Cardiac's specialist directory. Great place to start. The other question that I think you can ask the cardiologist to determine whether a specialist is, how many patients do you see with LMNA variants like me? If the answer is a dodge, if the answer is a duck and weave, if the answer is 0 or single digits, they may not be a specialist. So how can LMNA variants affect the heart? How do we evaluate and how do we treat? And we'll talk in broad terms here because LMNA has very specific disease for very specific individuals. And so the treatment is very individualized. So we'll talk in broad terms. LMNA can cause a number of different heart conditions. The first is conduction disease, where electricity needs to go from the pacemaker of the heart through the atria, the middle of the heart, the AV node, down to the ventricles. That can be disrupted. Some of the earliest signs that we see of LMNA disease is actually conduction delay in the heart. And we can see that by an ECG. It can present with arrhythmias, both from the top chambers of the heart, oftentimes atrial fibrillation, or from the bottom chambers of the heart, oftentimes ventricular. And it can cause heart failure through a type of remodeling of the heart muscle called dilated cardiomyopathy, which can run hand in hand with arrhythmias. So in terms of conduction disease, this is oftentimes how we see it present. This down at the bottom is a rhythm strip in ECG, which shows very severe conduction disease called complete AV block, where there's no communication between the top and the bottom chamber of the heart. People with conduction problems may feel tired, particularly with exercise. They can't get their heart rates up because the conduction doesn't work well. They can have low energy. They can have fainting or near fainting. The nice thing about this, the silver lining here, is a pacemaker oftentimes helps you feel better if this is the nature of your symptoms. This is the reason. Arrhythmias like atrial fibrillation, ventricular tachycardia, and a bit more severe ventricular fibrillation are commonplace in LMNA-mediated disease. This can cause a feeling of fast heartbeat, palpitations, chest pressure, not necessarily pain. So sharp stabbing pain is almost never the heart. Pushing, band-like tightness might be. Shortness of breath, near fainting, or fainting. All of these are things that should trigger an evaluation for these kinds of arrhythmias. What does evaluation look like? So I'm going to show you pictures of kids because I'm a pediatrician. So you can imagine, though, obviously this would be for adults as well too. 12-lead ECG is critical, right? All the stickers on the chest, the big printout with squiggly lines, very, very important as part of the initial evaluation. We send patients home on ambulatory, meaning walking around monitoring. This is a 24-hour holster put on this child. That's part of our routine evaluation to look for those arrhythmias. The ECG just gives you 10 seconds when those leads are on the chest. This monitor gives you 24 hours or more to look for those arrhythmias. So it's part of the routine monitoring. What about heart failure or cardiomyopathy? Of course, the symptoms here can be classic symptoms of heart failure: chest pressure, shortness of breath, not wanting to eat, abdominal pain when eating, weight loss, constipation, what's near fainting or fainting. All of these things should warrant evaluation. To look for this, echocardiogram, an ultrasound of the heart. Get very happy. This is a non-invasive imaging study. It's very important for us to look at the squeeze of the ventricular myocardium, to look at the chamber size, and to make sure that there's nothing muscular. So to summarize, kind of a broad evaluation, what that would look like, the first evaluation for an LMNA disease evaluation would be an ECG. Typically, that's repeated about every year, although that can change. An ambulatory 24-hour heart monitor, which can be longer in time if needed, but should be part of every evaluation. An echocardiogram to look at the squeeze of the heart. Cardiac MRI, which gives us a lot more information about the muscle of the heart, because an echo might look normal, but there might be scar there. And that scar can be picked up by the MRI. That does not need to be done generally every year. It's a big expensive test every 3 to 5 years, unless there's some other concern. Stress testing. So if you're playing sports, if your symptoms come out with exercise, stress test might be helpful. And then genetic testing. So if you do not know your test, it needs to be done. If you don't have the full report, get it. It's critical for this process. Oftentimes, blood work to look for things that can tell us about the stress of the heart or other non-cardiac features of LMNA, which people are at risk for, needs to be done at first evaluation. These have lots of different names, but things like troponin, BNP, CK, CKMB. And then we have lots of evidence that's emerging from the science that looking beyond the heart is critically important for predicting how the heart will do. And so looking for blood work like electrolytes, liver function testing, lipid levels, cholesterol levels in the blood might be very important. How do we treat? Well, pacemakers, like we talked about, is really important. If the electrical signals don't go from the pacemaker of the heart down to the bottom chambers of the heart effectively, pacemakers can help with that. They can be either transvenous if you're big enough to have one, which means the pacemaker can sit In the skin under the chest, the leads go through the big blood vessels going to the heart, and they can pace when needed. Or if you're little, they have to be surgically implanted, oftentimes in the tummy, and then the leads stitched directly to. If there are arrhythmias, another kind of device can be employed, an internal cardioverted defibrillator, ICD, and that can be same thing up here in the chest with leads into the heart, or in children that are smaller, stitched directly to the heart, or a number of different configurations. Medications can be very helpful here. Some of them are things like beta blockers, which might form the foundation of therapy in many, although not all. And then for the arrhythmias, different types of medications are often tried. Amiodarone, typically in adults, we tend to shy away from that in kids, but wanting to treat those arrhythmias are important, and then the ICD for arrhythmias are concerned. Big question that we find commonplace in our practice is, well, my child is an LMNA variant, and I've been hesitant to get gene testing because I don't want him to be labeled or her to be labeled, mainly because I want them to be able to play sports. And so the question is, can patients with LMNA cardiac or LMNA variants play sports? And the answer is yes. This is my son. He doesn't have an LMNA variant, but his sport of choice is kendo. This is a kind of a niche sport, but if you told him he can't do kendo anymore, he's going to feel terrible. He's going to lose a peer group. He's going to probably get a little bit sad. It's really important. So our goal is to keep kids active. Cardiac stress test that we do is central to that. And the best way that we can keep your child safe is to do that comprehensive evaluation, which includes a stress test, so that we can have what's called a shared decision-making conversation, which means the family lets us know how important sports are to the child. The child lets us know how important sports are to him or her. Our job in that equation is to provide you with a detailed and customized assessment of what the risk is. The risk is X, Y, or Z of having some sort of a problem with sports. With proper management, it's going to be low, but we should be able to give you numbers. And then we have a conversation. Does that risk, which is X, is that higher or lower than the benefit Y? And if you say the benefit Y is much higher, we as a family agree, guess who plays sports? Guess who plays unrestricted sports? We also know that in all disease involving the heart, no sports, no activity, no exercise is never the answer. Even in diseases that we think progress with high intensity exercise, no exercise is never the right answer. Because if you take a child, you give them a beta blocker, you put them on a couch, they will develop cardiac disease at other times. We want to avoid that. So staying active is important. Having shared decision making around sports participation, particularly for the young, is critically important. It's not to say that we don't think about how to prevent bad things from happening. A central part of this shared decision-making conversation is having an emergency action plan. What might happen if there was an event? Our job is to lower the risk as much as possible, but this is an important safety net. And the way we talk about it with families is your child's risk might be low, but if this plan's in place, you're going to help everybody. The child who doesn't know they have a cardiac diagnosis, yet playing sports with your child. Grandma and grandpa, when they come to the football game, it's going to help everybody. We've had families who have established emergency action plans for their child. A few weeks later, helped grandma and grandpa when grandpa had a heart attack, saved their life. So these plans are critically important. One resource for you all is Project Adam. Project Adam was founded by a family who lost a child when an AED was not available. And so they've taken upon themselves to build a nationwide foundation to help. Project Adam has resources and can actually go or can provide resources for individuals to go to schools, certify them, make sure they have a plan, and help them get an AED. A wonderful resource for families. There's affiliates all over the country. So you might take a mental note of where you are on this map and look to see if there's a Project Adam affiliate near you. And our goal is to be able to get kids who have been told they can never play sports again back to playing sports. For my closing few minutes, where can I get more information? You're taking the first step. You hear it in LMNA Cardiac meeting. LMNA Cardiac was designed for families. That's their singular mission. Stefan and Roger are passionate about this. They understand where you're coming from. This is a wonderful resource for you all. Another great foundation is the SADS Foundation, which if you're thinking about emergency action plans, templates that you can use to maybe jumpstart a conversation with your student. The SADS Foundation has these templates available. And very briefly, as Roger mentioned, I see patients too. This is us up in Philadelphia, Children's Hospital of Philadelphia, our Center for Heritable Arrhythmias, which is in the penthouse suite of the Burger Center, the outpatient building here. And our research lab is right next door. And so, this just sort of highlights for us how seriously we take rare disease like LMNA disease, and how I think pairing the best clinicians with the best scientists is really critical for our way forward. And with that in mind, you'll hear a little bit later from Cindy, who's in the back over there, about an important research project for you all to consider. For those of you who are in Durham, you've heard this before, but this is an effort that we are undertaking with our partners in Europe to be able to sequence as many individuals with LMNA variants as we can. And we're calling this LMNA, the LMNA Registry of North America. And the idea is if we know enough about how the disease affects individuals with LMNA, and we know enough about your genome, can we start to break down some of these questions about why is it that LMNA disease looks different from me than something else? Why is it that in the same family, individuals progress differently, maybe earlier or later, or have, quite frankly, very different diseases? One of the things that we would like to do is figure out, does the answer lie in your genome? Not just the LMNA variant, but everything else, 3 billion nucleotides that make you you. Are there signals everywhere else that might be informative? So to do this, we need as many people as we can to volunteer for this research so that we can learn from everyone's genome. So something to consider. There's a QR code if you want to get a little bit more information. You'll hear more from Cindy. And then there's a e-consent process. If you're inclined, you can get your consent here today and do a cheek swab if it's something you're interested in. This is the reason we do it. This is a young man who had a cardiac arrest and then was so excited he was doing so well, he decided, you know what, I'm going to turn 18 years old and tattoo this to my arm, much to the chagrin of his mother. But he doesn't let his cardiac arrest define him. In fact, he's tattooed it to his arm and he's active and he's proud. He's a survivor and he's doing really, really well. These are the kinds of things we want for our patients and families. There's another who this is a few minutes after his cardiac arrest. You can tell he's neurologically doing really, really well because he actually has not put down his cell phone. He's still texting. And so a testament to a good emergency action. And so with that, I think we have a few minutes. I'd like to thank you for your attention this morning, for your attendance here at this meeting, and I welcome any questions. Thank you all very much.
Thank you, Andrew. Great, always a pleasure to you. Right. Thank you for all this information. Are there any questions?
Thank you for this very nice presentation. So my question to you is, I'm sure that you also see female pediatric patients. How does the trip look like as they grow older when they get married and then want to have children? Can the heart sustain the high burden of pregnancy, or would they need special precautions along the way?
Pregnancy, in many ways, because you're giving blood both to yourself and to the fetus, is sort of like 9 months of cardiac exercise. That gets more and more intense as the fetus gets bigger and bigger. So pregnancy overall is one of those things that can accelerate not just this kind of disease, but lots of kinds of genetic diseases of the heart. And so it's very important that for individuals with an LMNA variant or variants that can cause cardiomyopathy, if pregnancy is something they're considering, to be followed closely, to have their risk established in advance, if possible, of the pregnancy, followed during the pregnancy, and then have a team in place, because it's a bit unpredictable, but it is a possibility. And so a little bit of planning in advance is key.
Any other questions? I have a small question. So from a pediatric point of view, when you're reaching the age of 15, 16, 17, the transfer might be to adult cardiology while the energy of the heart changes with it. So how do you deal with that?
I think in a best case scenario, because these are genetic diseases, that the specialists at your center take a family-based approach. So I know at Stanford, certainly at CHOP, if you're a pediatric patient with a heritable disease, we partner very closely with our adult colleagues who care for you when you turn 18, 19, 20. It's also really important because when they make a diagnosis, a parent, they have kids, we have to work closely together to make sure the kids are safe. So in a perfect scenario, if you've got that older child who's thinking about graduating to our adult EP colleagues, having questions about how is it that you interact? How is it that you care for entire families? Is a really important one to ask for your specialist. Sir, did you have a question?
I had a question. So like uh, in developing a action plan for young athletes, where do you draw the line as far as like citing the heart and training and developing for their sport of choice?
I think of exercise in sort of tiers. High intensity exercise for LMNA might pose a little bit more risk. However, that risk is definable, quantifiable, and reducible with optimal management. Moderate intensity exercise, which I think of as the stuff that we all need to do to maintain good cardiovascular health, not quite extreme sports, but the morning jog, cardiovascular fitness, the stuff where you can talk maybe in 1 or 2 word sentences, but you can still have a conversation, is moderate intensity. That's almost always the right answer. That's almost always okay, even in aggressive diseases where the heart gets worse with exercise. That's still the answer because if you don't do that, you're going to develop other cardiac conditions. The extreme or more strenuous exercise is that customizable risk benefit discussion. And it's up to the families. Our job is to say, here's what the risk is. Here's how we lower that. Here's the safety net, emergency action plan. What are your goals? And to the athlete, what are your goals? What do you want to do? And if everybody in the family says, we want to move forward and there is small identifiable risk, I say we move forward. Maybe one more question because I don't want to derail the whole schedule. Way in the back.
I wanted to go back to the topic of pregnancy, if that's okay. You defined it as 9 months of exercise. Exercise is usually something that produces a benefit, profit, when it comes to a woman with cardiomyopathy. In the long run, is that going to produce profit with her having this? Or is it going to produce, how do you say, a negative, what's the word? Is it going to be, a negative thing for her to go through this if she does have the baby?
I think what's key for pregnancy or for sports or really anything down the road is you're trying to predict what may or may not happen. We're terrible at that, especially in a disease like LMNA. We do understand what the risk factors are. And with a comprehensive evaluation, we can establish what risk factors and what risks exist at the present time. And we can do our best in predicting what anything, whether it's pregnancy, whether it's strenuous sports participation, might do to that risk over time. But then I would argue it's not up to us. It's up to the patient, the family, the people who have the lived experience to be able to judge what that risk means to them. And I think when we do that, we arrive at whatever the right answer is for that patient and that family. Thank you all very much.